just another few more seconds as folks are just starting to enter our room here. Okay, we're going to go ahead and get started. So welcome everyone to today's webinar on primary care access and opportunities here in the state of New York. My name is Andrew Phillip. I'm the Senior Director of Clinical and Population Health here at the Primary Care Development Corporation. Briefly, I'm a clinical health psychologist by training, and with BCDC, work with our clinical and population health team to on our large national portfolio of training, consultation, and technical assistance around everything from behavioral health and primary care integration to incorporating HIV services into primary care, care management, healthcare essentials like motivational interviewing, and other topics. And I'm joined today by my co-presenter, Mary Ford. She oversees our evaluation and analytics department here at PCDC, where they conduct ongoing research and work to analyze things like primary care access, as well as public health and the state of our approaches and outcomes related to the work that we do across the healthcare spectrum. Mary comes to us with a background in epidemiology and biostatistics in both the public and private health arenas. So we'll go ahead and get started here. Just a note, if this is your first time joining us at the Primary Care Development Corporation, PCDC, we've been around since the early 90s here in New York and also have a national presence. We're really started as a community development financial institution, so focused on transforming primary care primarily through investing and through advocacy, and then our practice transformation work. So as you can see, through the work since over these past 26 years or so, we've worked with thousands of organizations to really increase capacity to deliver equitable, critical primary care, as well as other related services, helped create or preserve over 15,000 jobs, created millions of visits, and we've leveraged over $1 billion to really enhance the infrastructure of primary care and related services. So I wanted to start with a poll today, just to acknowledge kind of where we're at and what's going on right now. So if you can answer the question that's popping up on your screen right now, we're curious what life is actually like for you right now. Are you tuning in today from a clinic somewhere? Are you in a non-clinical office building or setting? Are you working from home? And if you are working from home, do you have some sort of unique situation different from your normal? For example, are you caring for your children or parents or others there at home with you? So we'll leave this up for just a few seconds here. We're getting lots of votes coming in. Okay, great. And I think we can close the poll now and check out the results. So what we're seeing here is no surprise, especially here in New York State. Almost everyone, gosh, 85% of you are at home working as you otherwise would from a remote capacity. But I also want to recognize that a small number of people are in the clinic right now. And then also a decent number of folks are at home, but also dealing with other things besides regular day-to-day work, like taking care of children. And so I just want to acknowledge that, we know that some of you are tuning in from some unusual circumstances, and we're glad that you joined us, and we're going to take that into account. Okay, we can close our poll here. So taking us forward, again, just kind of acknowledging what's going on right now. You may have tuned in for our primary care summit that was really focused on increasing primary care investment yesterday. And we talked about this a little bit, but I don't think we can just totally function as business as usual, because of course we're in the midst of COVID. We've heard a lot from here in New York, from our governor, here in New York City, from the mayor, and of course, in each of your regions. And I just want to acknowledge that this is a unique moment, and of course in history, but obviously in healthcare and in our healthcare landscape. Now more than ever, we're really being called on across the board and across disciplines to not only do more, but to do more differently, to provide more services at the point of care and a larger spectrum of services. And that's part of what we'll talk about today. So really more than ever now is the time where we need a robust, highly functioning healthcare system. And especially it's important that we not forget primary care and behavioral health, those foundational access points for care, while acknowledging the need for things like hospital services as well. So I'm going to turn it over to Mary Ford to take us through and really go over our research that we've been doing around access in the state. And we'll be talking about a few particular applications of improving access as well.
Can you all hear me now?
Yes, we can hear you.
Yeah, okay, perfect. Sorry about that. Well, thank you for that introduction, Andrew. And thank you everyone for tuning in today as we discuss a few different areas of primary care access in New York State. So a little bit about some of the work that PCDC does. In addition to our primary functions, really lending capital to primary care practices and providers, and then also working on performance improvements directly with providers and practices. We have started over the last couple of years to delve more into some research and analytic areas around what access means in the primary care landscape. One of the reasons that we started this focus area is because we realized that access is something that really affects primary care at all levels of the work, from the patients, providers, to systems. And I think that today, really more than ever, as Andrew was mentioning, is something that is really becoming quite clear. So today we're going to give an overview of some of the work that we've done specific to New York State, both the approach that we have been taking to some of the analytics work, and then we're going to have two more in-depth discussions around key interest areas that we've been focusing on the past few years, which will be rural health and behavioral health. So first off, why do we care about access in terms of primary care? We know that primary care is the foundation of the healthcare system. We know that it's the cornerstone of healthy, thriving communities. But we also know that in New York State, as well as across the nation, having access to primary care is really critical to creating healthy communities and ensuring health equity, in addition to reducing healthcare costs. We also know that there are serious inequities in primary care access and delivery, again, across the state. Largely, these are driven by economics and some social determinants of health. But what really is access? Access has several different dimensions that we think are all equally important. Accessibility in terms of actual sort of geographic proximity. There needs to be providers that you can physically get to. Of course, we'll talk a little bit about telehealth a bit later on. Affordability, whether that's being uninsured, underinsured, or insured, but dealing with sort of complex systems of deductibles, co-pays, all of these things that we're, I'm sure, quite familiar with when dealing with physician visits. And then access in terms of care being comprehensive, that primary care can be the first stop and first sort of touch in the healthcare system, but that it should not only be able to identify and treat in an ongoing fashion any sort of medical or clinical conditions, but that it can also connect patients to different areas then of the healthcare system as needed. And then also accessibility in terms of it being ongoing and coordinated to ensure that patients are able to receive all of the care at a high quality manner that is needed. So when PCDC first started thinking about primary care access, we stumbled upon several different approaches to measuring access. And I believe Andrew had mentioned briefly, PCDC is currently doing some work around looking at the primary care spend, and any of you all who are familiar with this know that there are many different definitions of both primary care, and there are different ways that you can start to try to think about what primary care is. So we can think about primary care in terms of the physicians who are providing the care itself. We could think of primary care in terms of sets of services that are being delivered, either in conjunction or sort of regardless of the actual providers who are delivering these services. Or we could also think about primary care in terms of qualities of care, for example, being sort of the first touch or entry point to the healthcare system. So to capture primary care, I think PCDC, we realized pretty quickly that this wasn't going to be one measure. We weren't going to be able to capture one single data point that would be able to truly capture primary care access. So what we were able to do was sort of whittle down access into 4 domains or dimensions, which, oopsies, advanced for me. The first being the provider to persons ratio. So we were looking, again, this is how many providers there are per person sort of in a density sense. Looking at uninsured rates, realizing that having health insurance is a critical element of being able to access care. We also looked at the public insurance coverage, both for Medicaid and Medicare, and the percentage of primary care providers who accepted these 2 types of public insurance. And then as an attempt, I would say, to better understand quality of care being provided in the primary care sphere, we also looked at patient-centered medical home recognition, and so whether primary care providers were recognized with this status. The one thing that I'll definitely acknowledge here is that we took a very much provider-based definition of access, so really looking at where providers are in relationship to the population, and then looking at qualities that qualities of the primary care providers that indicate different elements of access. So not surprisingly, when we looked statewide at primary care access, access varied significantly across the state. Again, as may not be a surprise to many of you from New York and working in this field, most of the provider workforce is really concentrated in larger cities and towns. But while this is in some ways a reflection of the density of the population, because we were looking at the ratio here, this map on the right that's sort of a blue color, we were looking at the provider to population ratio. So this is accounting for the number of people living in the different counties. And one thing that we actually did find relatively surprising is that there are several counties in New York State that have fewer than 10 primary care providers. And another element that, again, probably not hugely surprising to many folks familiar with primary care facilities in the state is that a lot of the facilities here, this map that's kind of in the middle bottom of this slide looking at substance use treatment programs, a lot of facilities are really clustered along major highways. This obviously isn't surprising because it would certainly make these practices and facilities more accessible. but it means that for folks who are located in areas farther away from sort of these major transportation arteries, it's that much more difficult to access services. So then as we began exploring the measures of primary care access, sort of another question that arose as we were thinking through this is then, what about primary care need? So does access itself truly reflect the sort of need for primary care services? And we realized that the socioeconomic position and then the health status of populations in these communities is also really, really important when we're thinking about access. So, you know, perhaps healthier populations and those with a higher socioeconomic position may actually not need the same sort of quote unquote level of access to primary care because they have both perhaps less of a need for as much primary care and then have financial means to access services when needed. So in our report, we included several measures. A couple of them are just noted here. So we looked at factors such as obesity among adults. That's on the bottom left map. In the middle, we were looking at the disability among adults. We know that disability can certainly affect need for access and ability to access care. And then on the right map, premature mortality rates. We know that having high quality continued care, particularly for chronic conditions throughout the life course, can definitely support and extend the lifespan. So thinking about primary care in terms of premature mortality rates is a new area that we've actually seen some research begin to come out around. So then we wanted to take this one step further than just looking at primary care access and then measures of primary care need across the state. And we conducted what was a, yes, maybe for the biostatisticians out there, a rather simple analysis looking at the correlations between access measures of primary care, health status, and then the socioeconomic indicators. And you can, it's probably too small to really read here, but of course you can see all of this in the larger report. But we noticed that even at a county level, that increases in provider availability were associated with decreases in premature mortality rates. So folks living in areas with with more providers had longer lifespans. That provider availability was also associated with decreased percentage of obese adults, lower percentage of disabled persons, and then also across pretty much all of the health and socioeconomic position indicators, we noticed that these were very closely associated with rural area. So fewer providers in rural areas, increased premature mortality rates, greater rates of obese adults, and some of the other health status indicators, which led us to decide to do a deeper dive into rural access to primary care in New York State the following year. So kind of looked statewide, we wanted to understand better what was happening in some of the rural communities in the state. And we've known and heard throughout our work continuously that access to care is one of the most frequently cited and urgent health problems faced by rural populations. Again, many of the inequalities that we see statewide are really exacerbated in rural communities, driven largely by, again, economic factors, issues around insurance coverage, reimbursement, and the social determinants of health that can be very different in rural communities. So we did both an analysis of primary care access and need measures, but we also did some provider interviews. We conducted some provider interviews with primary care practitioners in rural communities. And I just wanted to read this one quote to you all, since it's really stuck out both for myself and many of my colleagues, which is, if you're in a rural practice, you really have to see everybody. You can't tell someone to go down the road. There's nothing down the road. So just very briefly, one of the interesting things about this analysis was the definition of what is rural, and a lot of different definitions of sort of metropolitan, urban versus rural. There's very clear definitions of what's a metropolitan area or an urban area, and then rural is just sort of everything left over. But we used what are called rural urban commuting area codes, or RUCA codes. And then based on some regions you can see here on this slide in New York, the darker yellow is indicative of the more rural areas of New York State, just to give a little bit of the lay of the land for anyone who's not as familiar with some of the geography of the state. So access to primary care providers in rural versus urban areas. The map on the right is the same one that we had shown for the statewide analysis. But then when we look at rural, small town, micropolitan versus metropolitan areas over on the left in this graph, we really see the stark difference in numbers of provider availability based on these different categories. So in rural areas, there are about 3.4 primary care providers per 10,000 persons, where in metropolitan areas, there are about 15 providers per 10,000 persons, meaning there's about 5 times more providers in the counties, or sorry, rather in the regions that are metropolitan. So again, not only are there more providers, but in rural areas, patients are likely going to have to travel much farther to see a provider. So that's sort of the bad news, but some of the good news was around the responsiveness of providers in rural areas to really be able to see all of the patients that walk through their door. So you can see here in all of these graphs, actually, on the left specifically is looking at the percent of providers who accept Medicaid or Medicare. And you can see in rural areas here that providers are accepting higher rates of Medicaid and Medicare in rural areas. And then just for some context, you can see in this figure on the right that there are higher rates of older populations in rural communities, which again, the fact that more providers in rural areas are accepting Medicare, again, indicates responsiveness there. And then one thing that we also found quite interesting was that providers in rural areas have higher rates of being patient-centered medical homes. And in fact, much higher, in fact, nearly a bit more than double, actually, the rates of metropolitan areas. And one of our hypotheses around this is that in New York State, providers who, let me make sure my internet didn't freeze there for a second. Sorry, so in New York State, providers who accept Medicaid get a bump in Medicaid payments for being PCMH recognized. And so these providers would be in rural areas be getting some small but increased Medicaid dollars for the PCMH recognition. So I'm going to go through these quickly, but we have, again, much more detail in our report where we're looking at some of the key challenges that primary care providers were facing in rural areas. So again, not surprising, the primary care workforce shortage really exacerbated in rural communities. This really seems to result in the providers in these rural areas working longer hours, having a greater workload, and really having to play the role of many different types of providers. So not just, sort of set of primary care services, but having to provide behavioral care, behavioral health care, and other things. So really thinking through and then actually implementing provider recruitment and retention strategies are really essential in rural areas. Somewhat similarly to this, financial sustainability is a huge consideration. We know that in rural areas, Medicaid and Medicare do cover a larger percentage of the patients, which makes these providers much more sensitive to changes in reimbursement rates for these programs. And then rural hospitals face particular challenges resulting from changes in populations. The rural populations are shrinking, they're aging, and in some cases becoming increasingly more impoverished. And then not only that, but in different communities, different rural communities in New York, there are really differences in special populations. We don't have here certainly a comprehensive overview, but highlighting really two in particular. The first being substance users. The rural communities have definitely been hit hard. We hear a lot about the opioid epidemic in different communities in New York, but it's also really important to remember that there are also still other substance use problems, including alcohol, meth, that are still very much ongoing and embedded in some of these communities. And then so we developed a set of policy recommendations. Again, I'm not going to go through all of these in depth, and they're available in the report. But these are actually somewhat actionable recommendations generally at the state level that we believe will really help improve primary care access. One of the first recommendations that we've not heard before but think would actually be very important would be to redefine the geographic designations for reimbursement. Right now in the state Medicaid program, there's only upstate and downstate. But we think that adding a third tier based on rural area for the Medicaid base rate reimbursement would actually be hugely beneficial to rural providers and help sustain practices. We also, of course, are in support of preserving the coverage gains from the Affordable Care Act, and really believe there should be a focus on the expansion of incentives for the rural workforce. This is things such as tuition reimbursement, loan forgiveness, and again, strategies such as this that could be either kind of federal or state programs to incentivize primary care providers to come work in rural areas. And then I think a key incentive area is also to work with medical schools and residency to promote placement of residents in rural areas to encourage the students to then access or continue to work with these practices following medical school. And then lastly, but certainly not least, eliminating some of the barriers to care for rural populations Here, and again, just this set of recommendations, we really focused on things like looking at telemedicine as a method to overcome some transportation barriers. But of course, rural populations don't necessarily have adequate access to broadband or internet, making this a challenge. So this would actually take a kind of important set of support from the state, but could certainly expand access for many rural patients and communities. And then we'd also discussed a little bit about the transportation barriers, so expanding models around home visits, and funding for programs that could help physically transport patients to medical visits. But I think it's actually very interesting, again, particularly in these times where many of us are quarantined, if you will, at home, thinking about how not only would these really benefit the delivery of primary care in rural populations, but actually increasingly relevant to many both primary care but also public health challenges that we are facing. And so I think with that, I'm going to hand it over to Andrew, who will sort of pick up from here.
Great, thanks, Mary. And playing off of some of what you just described, particularly when we're talking about barriers to care, I think particularly in New York, where I think certainly we've been more, quite a bit on the ahead of the curve in many ways. We know that a huge access issue is really around both primary care and behavioral health. And certainly, to some of the points that Mary went over earlier, when we're looking at things like mortality gaps, lifespan, and access to multiple services without burdens around things like transportation, going from appointment to appointment, integrating multiple service types into single locations or systems of care becomes particularly important. So to that end, we're going to talk, I'm going to kind of lead us a little bit into applying this to integrating primary and behavioral health care. And then we'll leave some time for some discussion here. And also, as we're going, I just want to remind folks that we do have the chat feature in the Q&A. You can enter in your thoughts, reactions, also what you're doing and seeing there, and we'll talk about those at the end. And also, some folks have been asking about recordings and access to the slides. We'll be providing links to those after we're done today. So, on this topic of integrating primary behavioral health care, I won't belabor this point because I think, especially here, we've been talking about it a lot, but gosh, at this point, we really know that people who have both, well, first of all, people have predominantly mental health conditions, things like bipolar disorder, schizophrenia, severe substance use disorders. They die earlier. The numbers have been changing over the past 25 years, but we've known this for decades at this point. And still, unfortunately, this persists. And we also know that those same individuals are also dying from things like metabolic disorders that have connections to behavioral health conditions. And even more frustratingly, they often are not necessarily accessing primary care services. They're getting their services for their kind of primary concern, which is often behavioral health. But on the flip side of that, we also know that people with chronic medical conditions are also then likely to develop and later be diagnosed with more like mental health conditions. And we have this kind of interesting situation where even in primary care, although we can argue that the bulk of behavioral health services, if we just break it down very, very basically to just prescribing antidepressant medications, much of that happens in primary care. Yet when we talk to primary care providers, what we see is that they feel otherwise unequipped or unsupported, or just don't have capacity to really fully address behavioral health needs, from screening to intervention and follow-up in just the primary care visit with just that core primary care team. So we're going to talk a bit more about this. And as we're talking about integration, I'm always sensitive that particularly in New York, we have quite a split when we're in terms of bringing primary care services into behavioral health systems or vice versa. Sometimes people use terms like bi-directional integration or even reverse integration. We're going to kind of talk about this much more broadly. Some people, especially in New York, we're fortunate that we have the greatest density of certified community behavioral health centers, or CCBHCs. We also have quite a few federally qualified health centers. We have standalone behavioral health organizations, of course, primary care. We also have a lot of small practices. And so, I would argue that there's opportunities across the board for integrated care, regardless of the direction that we're talking about. Last year, PCDC, along with others and funded by the New York State Health Foundation, conducted a case study around behavioral health integration and really addressing barriers to integrated care. We worked with an organization that we helped arrange funding for, the Hub in East New York, which was a partnership between ICL and CHN. And many of you were actually a part of this. And what we saw there was a great example of two separate organizations, an FQHC and a behavioral health organization, joining together, creating a new space under one roof where the two organizations could offer primary care and behavioral health services in a full range, hand in hand, and really work together towards combining systems, towards information sharing, and towards really developing new processes and workflows to make it work. And so we conducted interviews with staff there. We conducted many site visits, interviewed a lot of other stakeholders. We also, in the course of doing this, broadened the conversation. We conducted, and again, many of you are actually here. You may see yourselves in some of these photos, but we worked with stakeholders from, government, of course, our state agencies like OASIS, the Office of Mental Health, the Health Department, also hospital leadership, academic medical centers, thought leaders, and others, to really bring them together and say, what are the current barriers to integration where you are? And then we took these, we brought it together. We held a primary care summit in the bottom photo there, where we shared some of the findings. And ultimately, this culminated in a set of really targeted recommendations for here in New York. And I'm only going to really highlight a few of these, but just to briefly go over kind of what we heard and what we recommended, it's probably what you're quite familiar with and what you've been seeing as well. At this point, we're all familiar with some of the barriers, I think, at the regulatory level towards integration, from like the physical space requirements towards billing. We've had issues around billing for same-day services for multiple provider types, actual construction requirements, egress requirements, licensure applications. These are areas where, the state agencies have really been working to come together to make recommendations and changes. Of course, also working on our systems of care around sharing information. We've worked with RIOs and others around this, but no matter how you do it, making sure that there's some sort of mechanism for sharing information at the point of care, but also at the population level. For example, we're talking about shared electronic health records, or at least mechanisms for them to speak to each other. Even at the federal level, really advocating for considering integrated care needs when certifying or advancing some of these systems. And then also, we heard a lot about duplicative systems that are in place around reporting requirements. For example, like if you have a SAMHSA grant, if you're a federal qualified health center and you're reporting data, UDS data to HRSA, perhaps you're also a patient-centered medical home and submitting data around that. Becomes very cumbersome, and all that's not direct access, it's going to certainly hinder efforts to expand access. And then, of course, education of the workforce, and I'll talk a lot about that, bringing together the broader team and expanding our definition of teams, and then also looking at financing and reimbursement to make this viable. And that's some of what PCDC has been working on, but also, I think we're just starting to see more around codes and opportunities to really start up these services financially. So again, I'm going to focus on just a few of these as it relates to our conversation around access today. And in particular, Mary and I have gone around all around the state. We've been up here in the city, but also up in Rochester and Buffalo, working with the Adirondack Health Institute and others to talk about whether we're looking at rural areas, if we're looking at urban areas, what are some of the features of accessing, particularly when we're talking about integrated primary and behavioral health care both. How can we improve access to these things? What are some of the barriers? I'm just going to briefly highlight a few of the highlights and where we're seeing innovation in New York State. We've been seeing more clinics utilizing things like mobile clinics to bring services to our patients. Mary mentioned transportation. Gosh, that's been a really tough issue, not only in just rural areas, but even in New York City. in other metro areas where it may only be 2 miles apart, but that could be several hours of transportation, especially when we consider the points that Mary mentioned around disability, age, and other factors that can even further hinder your ability to get around town. It just becomes a greater barrier. Telehealth, which I'm going to put a bookmark on, certainly, we're all talking about that right now. I'm going to talk more about that in a second. But particularly when we bring together integrated primary care and behavioral health, what we create is an opportunity for offering both sets of services in the same day, sometimes even in the same visit, and particularly in the same clinic. So no longer we're telling the patient to go across town or to come back in several weeks or to wait months for an appointment in a whole other area with a different provider, with a different healthcare system. We're giving them an opportunity to get this all in the same place. And to do this, one of the things that we're often doing is decreasing the length of appointment times, particularly in behavioral health. Sometimes even combining visits, like literally and physically doing that, where a behavioral health provider may be seeing a patient in tandem in the same visit, in the same office, in the same, literally in the same room with a primary care provider. I think this goes to finding creative solutions for co-locating clinics. Obviously we gave the example of the health hub, but we've seen this now in schools, bringing services into community centers, using urgent care centers that are co-located into behavioral health organizations. We're seeing that here in New York City. We're seeing a lot of success around home-based primary care, integrated primary care behavioral health services, where there's a team who travels to the patient, and that team will include primary care and behavioral health providers themselves. Using reminders, just to make sure that people are showing up to their visits. And then there's special considerations, and I'll talk more about this in a moment, when we're just trying to increase access to services, to make sure that our clinic grids are set up for integrated care, to make sure that we have same-day availability balanced with scheduled visits. And really, the pitfall of integrating services and access is that if we fall back on our traditional ways of doing things, like we just sort of plant a mental health person into a primary care environment, for example, but we don't change the way we practice care or the way we communicate, we just see kind of a reiteration of the same problems we had before, which is appointments being booked out months in advance, providers carrying a regular caseload and not being open to new patients. And that just doesn't work when we need to speak both the language and the needs of primary care and behavioral health. So a lot of what we talk about is just nitty-gritty things like making sure that the clinic grid is flexible and that it can accommodate the right types of appointments to address both sets of needs. So as I mentioned, I think telehealth is really is really kind of the topic of the day right now. There's already been calls for it in recent years, but of course, in the midst of COVID-19, this is really what we need to be talking about. It's what's on people's minds right now. And so in thinking about this, and again, I want to really acknowledge what's going on right now. I'll just say from my perspective, as a psychologist who's worked in primary care, but also listening to the field, I have some concerns right now, and I'm sure these aren't news to you. We have a population who, at this very moment, is increasingly isolated, and we've already been dealing with an epidemic of loneliness and isolation in our country for years now. I have concerns about increases in violence within the home right now, and abuse as families are not only together, but there's fewer opportunities for getting out of the house, getting support elsewhere, and of course, tension already increasing. There's some controversy around risk for suicide and whether, this is an acute concern right now. I would argue that either way, the conditions that we're in right now, where we're seeing people with increased stress and tension, concerns about income, job loss, putting off potentially access to services, and again, combining factors like isolation. If it's not a concern now, I think it's going to just continue to be a concern later, even more so. And of course, our suicide rates have not been going in the right direction for a couple of years now. And then also, I think about exacerbation of things that are already going on. And I actually thought about polling the audience on some of these things, but as people are getting out less, moving less, even just looking at us working from home, I predict that we're going to see an increase actually in pain. And of course, we've already been in the midst of an opioid epidemic, which has not stopped in this time. Substance use concerns, of course, I think these are only going to be getting worse now, but also thinking about other factors that contribute to health, things like medication non-adherence, and not only just patients refusing or not taking their medication on purpose, but even thinking about perhaps this is a moment where maybe I don't want to go outside, maybe I don't want to go to the pharmacy, maybe I'll put off filling that blood pressure medication because I don't really know if I need it in the first place. Maybe this isn't the time where I'm going to ask my doctor to start me on an antidepressant or even go in for that visit. And to that point, I'm also concerned about just generally, again, this issue of access, particularly being worse now in this moment, as people are across the board, I suspect, is going to start putting off some of their preventative care and health maintenance visits. This may not be the time, and we'll talk about this, where people are initiating behavioral health appointments. I've talked to a number of primary care providers that are actually closing their doors right now because they don't have the ability to offer telehealth services or their models don't support that. So we have these acute issues, but then if we look at the system as a whole, we're really in a point where we need to really address access and to make sure that we're not putting these things off. And so kind of the question I'd pose to the group here is, can integrated primary care and particularly behavioral health providers help address some of these things? And can we do that using telehealth right now? And so, I would argue, my argument's going to be actually yes, and yes, and across the board. So as we're, and our state agency's been pushing payers and others, and of course we're getting new guidance from the federal government that we can offer telehealth services for more. This is a particularly, but as we're doing this, and particularly as we're looking at increasing telebehavioral health services, what we're going to need to do is ask each provider type, whether you're a behavioral health provider or a primary care provider, to consider even more factors within a person's life. And in fact, what I'm talking about is these factors on the screen here. Is there an opportunity for behavioral health providers who are working with primary care providers to start asking questions about pain, to help their primary care teams feel confident and able to start screening for and addressing substance use conditions? Can behavioral health providers ask questions about medication, even medication around things like diabetes, cardiovascular conditions? Just asking, hey, are you filling those medications? What types of medications are you on? Are you seeing any barriers to that? Oh, you're not taking your blood pressure medication? Why is that? Have you talked to your primary care provider about that? Can I help link you up? Even thinking about the types of services that are usually offered in person ambulatory care, I think about things like physical therapy, weight management classes. We may be seeing a decrease in access to these things as well. And again, this is an opportunity for our behavioral health colleagues from an integrated perspective to start asking questions about physical activity, which can then lead into conversations around pain and other things. Again, it's an opportunity for us all to start doing more, and that's a move towards integrated care. So to that end, I just wanted to give a few really concrete examples where I see this opportunity to really increase the capacity of integrated behavioral health providers in particular to offer services to really increase access to care, particularly now if they're offering services via telehealth. So the most common conditions that I think there's opportunities for that we're typically not addressing, the first one is, I can't sleep, right? If I have a feeling, and feel free to chime in the chat, but if I were to ask you, has your sleep changed at all in the last couple of weeks? My guess would be that we've certainly seen some patterns changing as far as sleep goes. We know that sleep is highly correlated with everything from worsening of chronic pain to worsening of mood to increased risk for suicide, poor judgment, and other things. Thinking about even diabetes, gosh, my blood sugar is out of control. Maybe maybe folks are having decreased access to their usual medications, to testing. And this may also be a point, again, where people are putting off some of that screening and preventive health maintenance. And there's opportunities there, again, around pain and around substance use. And I want to just highlight a couple of ways to start increasing the capacity of integrated behavioral health providers to address these things. There's specific interventions, and actually on the slides we'll get, these are all linked to free resources. For sleep, we've developed, and the field is what I mean, is developed interventions for insomnia that can be conducted by behavioral health providers in the context of primary care during brief, even 30-minute visits. And if you don't know, CBT for insomnia or cognitive behavioral therapy for insomnia is really the gold standard intervention for insomnia. I'm a little bit concerned that right now we'll defer to things like using short-term medications to improve sleep, but we know that those don't really help in the long run for the most part. When we're talking about diabetes and really metabolic disorders in general, we know that there's massive comorbidity with behavioral health conditions. At PCDC, in partnership with the SAMHSA Center of Excellence for Integrated Health Solutions, right now we're in the middle of offering a free 7-part series on integrated primary and behavioral health providers addressing diabetes. You can access it through our website and the link on the screen. I'd encourage folks to join that. And then thinking even further down our list here. We've also put out guidance around pain. So there's an opportunity for behavioral health providers to start working with their primary care teams and patients directly, and this can be done over telehealth, to do things like addressing or offering cognitive behavioral therapy for chronic pain, having conversations with patients around increasing activity, focusing on function, decreasing dependency on opioids. We've also put out free guidance on that, and that's linked there around communication tools for both primary care and behavioral health providers to use with their patients on pain. And then, of course, substance use disorder, things like screening, brief intervention, or referral to treatment can be offered within the primary care context as well as behavioral health, and are opportunities for both types of providers and provider types to really work together to increase access to substance use services and screenings. So I want to leave some time for conversation, but really just thinking, we can think about access very broadly from like creating physical space and infrastructure, sending services out to our patients, using telehealth. But I would argue even in our individual clinical interactions with patients and those of us who are overseeing clinics and systems of care, now is really a time for us to address access by increasing the capacity, the training, and the skills of our clinicians to offer a broader range of services that really look at the whole person. And so these are just a few examples of those. And at the end of the day, and I know this is an oversimplification, but by doing these things, we're doing what's right for our patients. There's so much uncertainty right now, from looking at things like HIPAA, telehealth, and I'm pleased that increasingly the guidance that we're seeing is to do the right thing for the patient, and then we'll go from there. So I'm going to hand it back over to Mary to kind of sum us up, and then we'll go into a Q&A. And again, use the chat feature there. Let us know what your experiences are, and especially what your needs are.
Thanks, Andrew. That was a great summary. And so really just in conclusion, again, we wanted to share some of the work that we have been doing to date, but next up on our docket is that we are interested in continuing to explore different elements or dimensions of access, and hopefully identifying some of these areas to explore through different partners. We know that folks across the state are both interested in this and in many cases doing some work in this area, so we'd be very interested in hearing from any of you on different ways that either we could explore some of these areas or potentially support your own work. And then also using these findings to target opportunities, and then of course actually improve access, and continuing to sort of monitor and look at access factors across the state, and hopefully we'll see some positive outcomes through this.
So we've started to get a few questions, and again, folks, feel free to use the chat and the Q&A to, again, list out any thoughts you have, questions, or even just what you're doing. One of the questions that's come up is, looking at particularly rural FQHCs and behavioral health providers, asking, does it seem like they're actually, we've been hearing, are they more kind of able or prone to collaborate together than some of their urban counterparts? And is there a trend towards that in New York State? Mary, have you heard anything about this? Do you have any thoughts? I'll comment on it as well.
The, question about the collaboration?
Yeah, and is there anything unique about rural areas that can really enhance this? Are we seeing more of it in rural areas?
So I don't think we have any sort of hard evidence, at least nothing that I've seen, but I think we certainly have quite a bit of anecdotal evidence around this. Certainly one of the key themes when we were speaking to providers in rural communities was this idea and sort of hunger almost for collaboration. And in many cases, really a reliance on collaboration, for example, with specialty care, and even sometimes just with sort of support around, hey, how are you guys keeping your doors open? Facing many of the same challenges that other rural providers were, and really kind of linking services together across the state. So I think there's certainly an openness and willingness across rural providers that is certainly unique, although again, we don't have, hard data on this.
Yeah, and that's, I've seen the same things, and so we've been, this past year has been a really active year. We've also seen, we've been out in rural areas of New York and also just rural areas of the country. And again, anecdotally, I would say we actually are seeing, there's a certain, in rural areas, there's, I think just historically, there's kind of this self-sufficient, we'll figure it out, we'll make it work kind of mentality, which I've always really admired. And so there's already been a creativity towards finding new ways to, I would argue, really get service to people, but also to integrate care. In many ways, it's been out of necessity for years, even before now. We know that providers in rural areas, I've been in meetings where people have said, I'm the only behavioral health provider for 5 hours, right? So the need to access and to make services more available to people has already been there. And yeah, so they're using things like trying to creatively use transportation, partnering with ride-sharing platforms when available. But in more and more in rural and even frontier areas, which we do have in New York State, a lot of times it's either going to be telehealth or it's going to be bringing those services out to where the individuals live or where they can access them. And also we've been hearing, as we're talking about telehealth, we also know that broadband services aren't available everywhere. And so it's causing us to look at other things. I think that includes using telephonic-based care, which there's research to support the efficacy of, particularly with established patients. And then also using blended care, where we're using a combination of visits and remote care, utilizing other tools like apps in tandem with good care. Let's see, so we're getting some other questions. Folks are asking about if we're releasing any other reports on behavioral health or access. We're certainly continuing to do research in this area. To Mary's point about concrete data and information, what we're looking at right now is where is integrated care happening and what does it look like? Although there's sort of general definitions for integration and for a lot of these services, it's been hard to identify, and some of them move towards CCBHCs, things like that are giving us a more standard definition for even just behavioral health care that we can measure, but we'll be putting out more information on that. Let's see, we have a question of, have you observed any trends specific to pediatric practices or any recommendations for increasing access for families where kids might be covered, but the parents are not? And I can speak to this one, and Mary, if you have any other kind of thoughts. So there's some good models, like in Massachusetts, the McPAP program, for example, of increasing pediatric psychiatry access, certainly. But it can be difficult when services aren't available for both the child and the parent or the family member. I think folks from the state are really doing good work to improve access to maternal and child health. But it creates complicated judgment calls of if a pediatric patient is the primary individual that we're focused on, that we are reimbursed to cover, how much of the visit can we spend addressing the parents, for example, substance use issues or health conditions or needs there. But as we're starting to see more co-located services in schools and other areas, I think we're increasing access to this, but I don't know, Mary, if you've seen anything else to that point.
This hasn't actually been an area that we've, at least through our work, my unit's work, specifically looked at. So I think I'll defer to your answer, Andrew, but this is a really interesting question. And I think one we'd be interested to see if there are any trends that we can identify.
Yeah, and the state has technical assistance centers specific to maternal and child health. And also through some of the McTech programming. If folks follow up with me over email, I can send you some links to those. So there are innovative programs happening here in New York specific to pediatric services and family services. So we can kind of have a whole other discussion just about those. see what other questions we have. People are asking about access to the reports, access to the data. So we have all of the reports available at pcdc.org/resources, and we'll be sharing a link to those as well as to today's recording and the slides with folks over email. And those are even available right now, the reports on our website. I think the data sources themselves are a little bit more complicated. Mary, I don't know if you want to comment on those.
Definitely. So one of the reasons that we've been really excited about our reports and some of the data elements in there is that these are actually unique insofar as they're ones that we obviously used other data sets for, but really have derived a lot of these access measures ourselves. And while we think the reports are great, we actually are very interested in making sort of more public some of the underlying data where possible. So we are working this year to create some online dashboards where data would be more queryable by the end user. You could download some of the data sets as well. So those will probably be kind of coming along in the next couple of months, and we'll definitely be sending out some updates via our newsletters and definitely website as soon as those are available. But we hope that people are able to use the reports in the meantime, and then when the data are available, can actually use those to inform their work.
So we have a few more questions that are still coming in, but we are at time, and I want to be respectful of folks' time, and I know people start kind of dropping off. So just again, want to thank everyone for joining us. Thank you, Mary. Thank you, of course, of our our colleagues and our sponsors at the state for helping to enable this work. We'll be in touch with more information. Again, join our series, our SAMHSA sponsored series you can access through our website. Tuesday, we'll be holding a listening session on integrated care, and we'd encourage you to join that and share out what you're seeing and what you need. We'll be sharing more resources. And again, everything's accessible at our website at pcdc.org. Keep in touch, keep letting us know what your needs are, and we'll do everything we can to address those things. Thanks, everyone.